So this question about whether we can de-escalate HER2 therapy in frontline metastatic disease is a very interesting question. And there are prospective studies that are looking to answer this question of, oh, based upon ctDNA, can you make that decision? Do not do that in clinic now. We don't have prospective studies that have been reported yet, but those studies are ongoing, including some studies that are being led by Heather Parsons. And so I think that that may be where we are going. I think it's an individualized conversation with the patient. I think that it's important to know the risks and benefits. Sometimes my conversations with patients are, if it's not broken, do we really need to try to fix it? Also understanding for this particular patient that, really she could also be continuing taking endocrine therapy um, and not stopping therapy in total. I think it depends on the extent of disease and tolerability, et cetera, et cetera. And so we also know from studies that, the estrogen receptor and HER2 like to communicate with one another. So if you're doing just endocrine therapy, then there's a risk that, you can develop some resistance. And so I wouldn't say that there's any one size fits all approach. Don't use circulating tumor DNA to make these decisions. And it's really the risk benefit and individualized conversation based upon the things that I had mentioned.